Bones are living tissue. This is the fact that most people never quite absorb, despite having heard it at some point, because the intuitive sense of bone as something rigid and fixed and essentially inert is so powerful that the biological reality of bone as a dynamic, constantly remodeling tissue that responds to the forces placed upon it and to the nutritional environment it inhabits tends to remain abstract and somehow unconvincing. But this fact, the living, responsive, constantly changing nature of bone tissue, is the foundation on which everything meaningful about bone health after 60 rests. Because if bone were simply the fixed and inert material it intuitively seems to be, the story of bone health and aging would indeed be the story of inevitable decline that many people have accepted as simply the way things are. The fact that bone is living and responsive is what makes the story genuinely different, genuinely more hopeful, and genuinely more within the influence of individual choices than the resigned acceptance of bone loss as an unavoidable feature of getting older would suggest. The biology of bone remodeling is worth understanding clearly because it is what makes both the problem of age-related bone loss and the solutions to that problem comprehensible. Throughout life, bone tissue is continuously being broken down and rebuilt through the coordinated action of two types of cells called osteoclasts, which dissolve old bone tissue, and osteoblasts, which build new bone in its place. In younger years, this process operates in balance or in the bone-building direction, with osteoblast activity matching or exceeding osteoclast activity, resulting in stable or increasing bone density. After the mid-30s, and accelerating significantly after 60 and particularly after menopause in women, this balance shifts in the direction of net bone loss, with osteoclast activity outpacing osteoblast activity, and the result being a gradual reduction in bone density that, when it reaches a clinical threshold, is called osteoporosis. The numbers associated with osteoporosis and its related fractures are sufficiently striking to warrant stating clearly. Osteoporosis affects an estimated 200 million people worldwide and is responsible for an estimated 9 million fractures annually. In the United States alone, approximately 1 in 2 women and 1 in 4 men over the age of 50 will experience an osteoporosis-related fracture in their remaining lifetime, making it one of the most common and most consequential health conditions of older age. The specific fractures that osteoporosis most commonly produces at the hip, the spine, and the wrist carry consequences that extend far beyond the immediate pain and healing period. Hip fractures in particular are associated with mortality rates of 20 to 30% in the year following the fracture in older adults, largely because of the complications of surgery, immobility, and the general physiological stress of major injury in a body whose reserves are limited. Among those who survive, a substantial proportion never regain their pre-fracture level of function, with permanent increases in dependence and permanent reductions in quality of life that could in many cases have been prevented with more proactive attention to bone health in the years preceding the fracture. Understanding the specific factors that accelerate bone loss after 60 helps in understanding the specific interventions that can slow or reverse it. Estrogen plays a critical role in regulating the bone remodeling balance, suppressing osteoclast activity and supporting osteoblast function, which is why the rapid decline in estrogen that occurs at menopause produces a phase of accelerated bone loss that can be dramatic in some women and that accounts for the significantly higher prevalence of osteoporosis in women compared to men. Testosterone plays a similar though less dramatic role in men, and the gradual decline in testosterone with aging in men contributes to their own, slower bone loss trajectory that nonetheless becomes clinically significant after 70 in many cases. Beyond the hormonal dimension, the decline in physical activity that commonly accompanies aging removes one of the most powerful stimuli for bone formation, because bone responds to mechanical loading by increasing density in the specific areas being loaded, and reduced loading leads to reduced density in those areas. The nutritional changes of aging, including reduced appetite, reduced absorption efficiency, and in some cases genuinely inadequate intake of the specific nutrients bone requires for its maintenance, contribute significantly to bone loss that is partly nutritional in origin and therefore partly correctable through nutritional intervention. And certain medications extremely commonly used in older adults, including corticosteroids, proton pump inhibitors, certain antidepressants, and certain diabetes medications, have bone-depleting effects that are often not adequately communicated to the people taking them, and that require specific attention and management. Against this background of genuine and significant bone health challenges in older adults, the evidence for what can actually be done to prevent and address bone loss is both robust and genuinely encouraging. The interventions that work are specific, accessible, and supported by decades of research across multiple disciplines, and understanding them clearly provides the foundation for making choices that genuinely protect bone health in ways that the usual vague admonitions to take calcium and do some exercise do not adequately convey. The nutritional foundation of bone health is more complex than the calcium-centric message that most people have received suggests, and understanding the full nutritional picture is important for making choices that actually support bone maintenance, rather than simply providing one nutrient in isolation from the others it requires for effective action. Calcium remains genuinely important as the primary mineral component of bone and the one whose adequate provision is most directly necessary for bone building and maintenance. The recommended daily intake for adults over 50 is 1,200 milligrams per day, a level that many older adults do not achieve through diet alone. Dietary sources of calcium include dairy products, fortified plant-based milks, tinned fish with soft bones including sardines and salmon, tofu made with calcium sulfate, and certain green vegetables including broccoli, kale, and bok choy. When dietary intake is consistently below the recommended level, calcium supplementation can address the shortfall, though the preference should always be for dietary sources where possible, because the food matrix in which calcium is delivered appears to affect its absorption and utilization in ways that benefit bone health beyond what isolated calcium supplementation provides. The relationship between calcium and vitamin D is so close and so functionally important that treating them as separate topics misses the practical reality that calcium cannot be effectively absorbed and utilized without adequate vitamin D. Vitamin D is essential for the production of the calcium-binding proteins in the intestinal lining that move calcium from the gut into the bloodstream. And without adequate vitamin D, even generous calcium intake achieves much less than it would in the context of optimal vitamin D status. For adults over 60, the likelihood of vitamin D deficiency is substantial for all the reasons already discussed in the vitamins piece of this series, making vitamin D supplementation in the range of 1,000 to 2,000 international units daily a genuinely important component of bone health management for most older adults, with blood level monitoring to guide appropriate dosing where possible. Vitamin K2 is the third nutrient in the bone health triad that most people have not heard enough about, and its specific role in directing calcium to bone rather than allowing it to deposit in soft tissues and blood vessels is genuinely important to understand. Vitamin K2 activates a protein called osteocalcin that incorporates calcium into bone matrix, and it also activates a protein called matrix GLA protein that prevents calcium deposition in arteries and other soft tissues. In the absence of adequate K2, calcium that is absorbed from the gut may be deposited in arteries and other soft tissues rather than being effectively incorporated into bone, which is part of why some research has found that calcium supplementation without adequate K2 status may be associated with cardiovascular concerns, while adequate K2 appears to reduce this risk. Vitamin K2 is found in fermented foods including certain cheeses and the Japanese fermented soybean product natto, and is also available through supplementation in doses of 90 to 180 micrograms daily. Protein is a nutritional factor in bone health that is far less discussed than calcium and vitamin D, but that plays important roles in bone maintenance that research has increasingly clarified. Bone matrix is approximately 30% protein by weight, and the collagen that forms the flexible structural framework of bone requires adequate dietary protein for its synthesis and maintenance. Research has found that higher protein intake within a healthy dietary range is associated with better bone density and lower fracture risk in older adults, countering an earlier concern that high protein intake might be harmful to bone through effects on acid-base balance. The practical message is that the emphasis on adequate protein intake for muscle maintenance, already discussed extensively in this series, simultaneously serves bone health and represents another convergent reason for prioritizing protein in the diets of adults over 60. Magnesium, phosphorus, zinc, and silicon are additional minerals that play supporting roles in bone health and that warrant at least brief mention as components of the overall nutritional picture. Magnesium is involved in over 300 enzymatic processes in the body and plays specific roles in bone metabolism, with research finding associations between magnesium deficiency and reduced bone density and higher fracture risk. The common observation that older adults are frequently magnesium deficient, combined with the widespread presence of magnesium in the bone health supporting foods already discussed, including leafy greens, nuts, seeds, and legumes, reinforces the value of a diet based around these foods for bone health alongside their other demonstrated benefits. Physical activity is the second major pillar of bone health maintenance after nutrition, and the specific type of physical activity that provides the most direct bone protective benefit is important to specify, because not all exercise is equally bone building. The stimulus for bone formation is mechanical loading, the forces placed on bone during weight-bearing activity and muscle contraction, and specifically the novel or unusually high forces that signal to the bone remodeling system that greater density is needed in the areas experiencing those forces. This specificity principle means that the bones that benefit from any given activity are specifically the bones being loaded by that activity, making a variety of weight-bearing exercises targeting different skeletal areas more comprehensively bone protective than any single activity. Weight-bearing aerobic activities, those performed on the feet against gravity, provide genuine bone benefit that swimming and cycling, despite their other health benefits, do not provide to the same degree because the buoyancy of water and the support of the bicycle seat respectively reduce the gravitational loading that stimulates bone formation. Walking is the most commonly recommended and most widely practiced bone-supporting activity, and while it is genuinely beneficial, it is less potent as a bone stimulus than activities with higher impact, because the skeleton adapts to the loading it regularly experiences, and the loading of ordinary walking may not be sufficiently novel or intense to drive continued bone adaptation in someone who walks regularly. Adding variations like stair climbing, brisk walking with a weighted vest, or brief periods of more vigorous walking interspersed in the usual walking pace can increase the bone stimulus beyond what level walking alone provides. Resistance training provides bone benefit through the forces that muscle contractions place on the bones to which those muscles attach, with research consistently finding that resistance training programs produce meaningful increases or at minimum meaningful reductions in the rate of decrease in bone density at the specific skeletal sites being trained. The hip and spine, which are the sites of the most consequential osteoporosis-related fractures, are effectively trained through the resistance exercises already described in the muscle-building piece of this series, including squats, hip hinges, lunges, and deadlifts in their various modifications appropriate for older adults. The convergence of bone health benefits with the muscle-building benefits of resistance training makes it the single most important form of exercise for the comprehensive physical health of adults over 60, addressing simultaneously the two most significant physical health vulnerabilities of this life stage. Higher impact activities, including jogging, dancing, jumping, and impact-based sports, provide particularly potent bone stimuli because the forces generated at ground contact are multiples of body weight and provide a different quality of loading than lower impact activities. For older adults without contraindications, Some degree of impact activity, even if it is simply brief periods of jogging interspersed with walking or some simple hopping movements while holding a support for safety, provides bone stimulation that lower impact alternatives do not fully replicate. The key is matching the impact level to the individual's current bone density, joint health, and fitness level, starting conservatively and progressing gradually under appropriate guidance, rather than either avoiding all impact entirely or adopting impacts that are beyond what the current skeletal status can safely accommodate. The medical management of bone health after 60 involves several important elements that go beyond diet and exercise, and that many older adults are either not accessing or not fully utilizing. Bone density testing through a DEXA scan, which measures bone mineral density at the hip and spine and produces a score called the T-score that expresses density relative to young adult norms, is the standard diagnostic test for osteoporosis and osteopenia, the intermediate state of reduced density that precedes osteoporosis. Current guidelines recommend DEXA screening for all women over 65 and for men over 70, and for younger individuals of either sex whose risk factors suggest elevated fracture risk. Many older adults who would benefit from this information have never had the test, and actively requesting it if it has not been offered is an important step in understanding one's bone health status and making informed decisions about management. The medications available for osteoporosis treatment have advanced significantly and represent genuinely important options for people whose bone density has reached the osteoporotic range or whose fracture risk assessment indicates that pharmacological treatment is appropriate. The bisphosphonate class of medications, including alendronate and risdronate, work by inhibiting osteoclast activity and have been shown in clinical trials to reduce fracture risk by 30 to 50% at various skeletal sites. Denosumab, a biologic medication that works through a different mechanism to reduce osteoclast activity, provides an injectable alternative for those who cannot tolerate oral bisphosphonates. Romosozumab and teriparatide represent more advanced options that actually stimulate bone formation rather than simply slowing its loss, providing the possibility of genuine bone density gains in people with severe osteoporosis rather than simply slowing further deterioration. The decision about whether pharmacological treatment is appropriate for any individual requires a comprehensive assessment of bone density, fracture risk, and overall health status that should involve a healthcare provider with expertise in bone health management. Fall prevention is an aspect of bone health management that operates in parallel with increasing bone density, and that is at least as important from the perspective of reducing fracture risk. A bone that does not fracture because the fall that would have caused the fracture did not occur is equally a protected bone compared to one with higher density that withstands a fall, and the practical importance of fall prevention as a fracture prevention strategy is underscored by the finding that the majority of osteoporotic fractures in older adults are the direct result of falls rather than the consequence of forces that would have exceeded the fracture threshold of even healthy bone. The risk factors for falls in older adults, including muscle weakness, balance impairment, medication effects, home hazards, and vision problems, are extensively documented and extensively modifiable, making fall risk assessment and reduction a genuinely powerful component of any comprehensive bone health strategy. A home safety assessment, conducted either independently or with the help of an occupational therapist, can identify the environmental hazards that contribute to fall risk in the living environment, including loose rugs that can slip, poor lighting that reduces visibility, absence of grab bars in the bathroom where many falls occur, and cluttered pathways that create tripping hazards. Addressing these hazards through simple modifications, securing or removing rugs, improving lighting particularly at night, installing grab bars in the bathroom and near any steps, and clearing pathways of clutter reduces the environmental contribution to fall risk in ways that require no ongoing effort once the modifications are made. The medication review already emphasized in the warning signs and blood pressure pieces of this series is equally important for fall prevention, as several medication classes and medication combinations produce dizziness orthostatic hypotension, and impaired coordination that meaningfully increase fall risk. Vision examination and correction is another underemphasized component of fall prevention because visual impairment is a significant contributor to fall risk in older adults and one that is often more correctable than people assume. Cataracts, which cause significant visual impairment in a substantial proportion of older adults, are surgically correctable with a procedure that has very high success rates and that has been shown in research to reduce fall risk significantly in people with significant preoperative visual impairment. Ensuring that glasses or contact lens prescriptions are current and that any correctable visual impairment is being addressed is a straightforward fall prevention measure with implications for bone health that extend far beyond the direct visual benefit. The psychological dimension of bone health after 60 encompasses both the anxiety that an osteoporosis diagnosis or the experience of a fracture can generate, and the particular challenge of maintaining the physical activity that bone health requires when fear of falling or fear of another fracture creates reluctance to engage in the kinds of loading activities that would most benefit the skeleton. This fear-activity cycle, in which the fear of injury from activity leads to reduced activity that weakens bones and muscles and consequently increases the actual risk of the feared injury, is one of the more important and more commonly encountered challenges in bone health management for older adults. Addressing it requires both the reassurance that comes from understanding what types and levels of activity are actually appropriate and safe given individual bone health status, and the practical confidence building that comes from beginning activity with appropriate support and gradually demonstrating to oneself that the feared consequences do not materialize with appropriate exercise. Working with a physical therapist who has experience in bone health management to design and initially supervise an exercise program is valuable not only for ensuring that the program is appropriately designed, but for providing the supervised experience that builds confidence and reduces the fear that might otherwise prevent adequate engagement with the exercise that bone health most requires. The combination of that professional support with a clear understanding of why the exercise matters and how it works, the kind of understanding that this piece has aimed to provide, creates the conditions for genuine and sustained engagement with the physical activity that is the most powerful non-pharmacological tool available for maintaining bone strength into and through the later decades of life. The honest bottom line about bone health after 60 is one that balances realistic acknowledgement of the genuine challenges with genuine appreciation for the genuine possibilities that the evidence supports. Bone loss after 60 is real and it is significant, and its consequences when left unaddressed can be severe, but it is also substantially modifiable through the combination of optimal nutrition, appropriate physical activity, medical management where indicated, and fall prevention that represents the comprehensive approach to bone health that the research supports. The bones of a person over 60 have not finished responding to the care they receive. They are still living tissue, still capable of forming new structure in response to appropriate loading, still capable of maintaining density with adequate nutritional support, still capable of being meaningfully stronger a year from now than they are today if the right inputs are consistently provided. That capacity does not last forever, and the earlier attention to bone health begins in the later decades of life, the better the ultimate outcomes will be. But it exists, and using it wisely and consistently is among the most important investments in long-term physical independence and quality of life that anyone over 60 can make.